Welcome to the deep dive. We're doing something a little different today. We're taking content you, the listener, sent in and turning it into a really focused, high-yield revision session aimed squarely at the MSRA.
Yeah, think of it as your personal audio flashcard almost.
Exactly. And today's topic, pyogenic granuloma. Our mission basically is to cut through all the detail, pull out the absolute must-know facts for the exam, and, make it stick. No dry lectures, just a clear breakdown.
And it's a great choice for MSRA focus. Pyogenic granuloma is common. You'll definitely see it. And it pops up in exam questions quite a bit, dermatology, GP stuff.
Right.
It really tests if you can spot it, know what it does, and crucially, tell it apart from, well, nastier things. Getting this right, definitely good for your score.
Okay, let's dive right in then. The absolute first hurdle with this one is the name, isn't it? Pyogenic granuloma. It sounds infectious or like some specific inflammation, but that's not quite right.
That's the perfect starting point, actually. Because, the name is, well, seriously misleading. Pyogenic makes you think pus, infection. Granuloma suggests a specific inflammatory reaction.
That either?
Nope, neither. What it is a common, and this is key, benign vascular tumor. Skin or mucous membranes. It's basically a really rapid overgrowth of tiny blood vessels, capillaries, and some inflammatory cells mixed in.
Okay.
So you'll see this like fast-growing red or maybe reddish-brown bump. Sometimes it's called granuloma telangiectaticum too, maybe slightly more accurate, hinting at the blood vessel thing.
Right, granuloma telangiectaticum. So benign vascular tumor. Got it. If the name's wrong and it's not infection, what does trigger this, this sudden burst of growth?
Yeah, good question. The exact why isn't always crystal clear, but it often seems to be a reactive thing, like an over-the-top reaction to something pretty minor.
Minor, like
Like a tiny cut, bit of skin irritation, maybe bumping yourself, even an insect bite sometimes. But, and this is interesting, there are also really strong links to hormonal changes and certain drugs.
hormonal changes. You mentioned pregnancy earlier.
Yes, pregnancy is a classic trigger. They're much more common then. Other things linked are like ongoing inflammation in an area or maybe some underlying vascular issue there already. There's some research hinting Staph aureus might be involved, maybe on irritated skin or possibly even viruses, but that's less certain. What's clearer is the medication link.
Which meds?
Things like retinoids, some protease inhibitors used in HIV treatment, certain chemotherapy agents. So if you see a patient on one of those who suddenly develops this lesion, well, that could be the connection,
Okay, that makes sense. So building on those triggers, minor trauma, hormones, specific meds, who's most likely to get one? Are there definite risk factors we should know?
Absolutely. I mean, anyone can get one, any age, any gender, but yeah, they definitely cluster in certain groups. Kids, for one, often around, say, 6 or 7 years old. And women get them more than men. Which ties back to the hormones, doesn't it? Especially during pregnancy or even puberty. Trauma is a general risk factor, too. And those meds we just mentioned, oral contraceptives, are specifically noted as well. Oh, and having pre-existing vascular weirdness in an area might make you more prone, too.
So kids, pregnant women, people on certain meds, or after minor trauma. Got it. Let's dig into the how a bit. How does it actually happen? The pathophysiology.
Right. So think of it as that abnormal response again. Your body gets a little locked, right? It starts the healing process, making new blood vessels, calling in inflammatory cells, normal stuff. But with pyogenic granuloma, in that one spot, the process just goes haywire. It doesn't stop. Instead of controlled healing, you get this like uncontrolled, excessive explosion of capillaries and the cells around them, plus loads of inflammatory cells just hanging about.
So it just doesn't switch off.
Pretty much. Why that happens in response to something minor in one person and not another, or why hormones seem to flick that switch, well, that's the bit we don't fully get. But the core process, uncontrolled reactive blood vessel growth, like that analogy we talked about before, a tiny scratch that decides to build a dense little city of blood vessels instead of just patching itself up.
That really helps picture it. Okay, now, probably the most critical bit for the MSRA, and just, safe practice, telling things apart. What else could this rapidly growing red bleedy bump be? What are the differentials?
This is absolutely crucial because, PG is benign, fine. But several really serious things can look quite similar, especially early on and particularly in adults.
Right. Like what?
So you got to consider other vascular things like hemangiomas. But the big worry is skin cancer. We're talking Kaposi sarcoma, angiosarcoma. Even squamous cell carcinoma can sometimes look like an angry red lump that grows fast.
Yeah.
And really importantly, melanoma.
Melanoma, but aren't they usually dark?
Often, yes. But there's a type called hypomelanotic or amylotic melanoma. It lacks the dark pigment, so it can present as a pink or red bump that grows. That's a major pitfall.
Ah, okay. So that's why biopsy keeps coming up, right? It's not just confirming PG, it's ruling out these other potentially life-threatening things.
Exactly. Biopsy is vital, especially in adults, or if the lesion looks a bit odd, changes really fast, or just doesn't quite fit that perfect PG picture. Ruling out malignancy is priority number one.
Okay, let's try a quick MSRA-style scenario then. Picture this. GP clinic. A, say, 70-year-old man, worked outdoors for years, comes in, he's got this red lesion on his scalp, grew quickly over the last month, bleeds if he catches it on a comb. Based on that, pyogenic granuloma is on the list, but what are you really worried about?
Spot on. That scenario, the age, the sun exposure history, the location, scalp gets lots of sun, the rapid growth, the bleeding, it just screams, think differentials. PG is possible, sure, but squamous cell carcinoma, high up there, melanoma, absolutely need to rule it out. That patient needs a biopsy like yesterday.
Perfect. Shows how you apply it. Okay, stepping back slightly. Epidemiology. How common are these in the UK? And the age profile.
Yeah, it's considered pretty common here. And like we touched on, it often has this sort of bimodal thing going on, peaks in two main groups.
Right, the kids and...
Exactly. Young kids, often around 6 or 7. And then again, in young adults, particularly women, tying into those hormonal factors like pregnancy. So yeah, anyone can get one, but those are your classic demographics.
Okay, now let's paint a really clear picture. What do you actually see and maybe feel in clinic, the key clinical features?
Okay, so typically they start small, just a few millimeters, but the growth is rapid, days to weeks. That's a hallmark. They're raised bumps on skin or inside the mouth, for example. Color, usually bright red, maybe darker red or reddish brown, packed with blood vessels, remember? The surface can be smooth, but often it gets a bit eroded or ulcerated. And crucially, they are very friable.
Friable meaning easy to bleed.
Exactly. They bleed super easily. Slightest knock, bit of friction, and they bleed. Often, that's why people come in. They often look polypoid.
Like a little mushroom.
Yeah, kind of like a little mushroom or raspberry on a stalk, usually just one. But size varies. Common spots, hands, fingers are classic. Face, inside the mouth, gums especially, in pregnant women. Head, neck, upper body, arms, legs, even genitals during pregnancy. Usually painless, which is interesting.
Right.
But they can be uncomfortable if they rub on things, and the bleeding is obviously annoying or worrying. Oh, and one thing to watch for, particularly in teens or young adults sometimes after you try and treat one, little satellite lesions can pop up around the edges.
Okay, so that classic picture. Rapid growth, red, maybe stalk, bleeds like crazy, and that memory tip seems useful here. PG, pregnancy link, rapid growth, usually painless, polypoid shape, prone to bleeding, covers the basics nicely.
Yeah, that sums it up well.
So you see this lesion, looks suspicious. How do you actually investigate? What tests do you do?
Well, often the initial diagnosis is clinical. Look at it, hear the story, fast growth, bleeds easily, and yeah, pyogenic granuloma shoots up the list. But, like we hammered home, biopsy with histology is really strongly recommended.
To be absolutely sure.
To be sure, and critically, to rule out those mimics, especially cancer. Looking at the cells under the microscope is definitive. The notes mention immunohistochemistry sometimes for specific markers, but that's less routine. And interestingly, dermoscopy.
The little handheld microscope thing?
Yeah, that. It might not actually be that helpful here.
Oh, why is that?
Well, because the lesion is just so full of blood vessels, under the dermoscope it often just looks like, well, a red vascular mess. It can hide the patterns you normally look for to tell it apart from other things like melanoma. So, useful for lots of skin lesions, but maybe less so for a classic PG.
Good to know. So, clinical suspicion high, but ideally biopsy for the final word and cancer check. Right, diagnosis confirmed, it is a pyogenic granuloma. How do we manage it? What's the plan?
Management really hangs on a few factors. Where is it? How big is it? Is it causing bother, like bleeding a lot?
Okay.
For really small ones, sometimes they can just go away on their own. So watchful waiting might be an option, especially if it's tiny and not causing issues. And remember the pregnancy ones, they often shrink right down after the baby's born.
Yes, so they might not need treatment.
Exactly. Worth waiting if possible. But for bigger ones, or ones that just won't stop bleeding or look awful or get in the way, then yeah, you need to intervene. And there are quite a few ways to do it.
Like what?
Common options are things like cryotherapy, freezing it off, electrocautery, using heat to burn it away, laser therapy is another one, or you can physically remove it.
Cut it out.
Yeah, excisional surgery, cut it out, maybe stitch the skin closed,
Yeah.
or methods like curettage and cautery, where you scrape the lesion off, then burn the base. That helps stop bleeding and tries to get any deeper bits to stop it coming back. Shave excision is similar. There are also some creams or gels, Mickey Mod cream, timolol gel, other topical beta blockers. Sometimes even oral beta blockers are used, maybe more in kids if they have lots of them. Oh, and steroid injections into the lesion are another possibility.
Wow, quite a list. Any key things when choosing?
Well, remember the biopsy point. If you freeze it with cryotherapy, you don't get a sample to send to the lab.
Ah, right.
So if there's any doubt about the diagnosis, choosing something like excision or curettage, where you get tissue at the same time as treating it, is probably smarter.
Yeah.
Also, just a specific point, that drug sodium tetradecyl sulfate. It's used for veins sometimes, but it's not licensed for PGs in the UK. Just one of those little exam facts, perhaps.
Good specific point. And after treatment, wound care is important.
Absolutely. Keep it clean, prevent infection, help it heal nicely, minimize scarring. And follow-up is key, too. You need to check it's healed completely. And big point here, check it hasn't come back. Recurrence is actually, well, pretty common.
Oh, really? Why do they come back so often?
It seems to be because those abnormal blood vessels can go deeper than you think, like little roots under the surface bump. If the treatment doesn't zap or remove all that deeper vascular stuff, yeah, it can just regrow.
So treatments like curettage plus burning the base or full excision are maybe better at preventing that?
They aim to be, yeah, trying to get the whole
Yeah.
depth. Referral might be needed sometimes, too. The notes mention referring if you're just not sure what it is, again, that malignancy concern, or if you do suspect melanoma, obviously. Also, if it keeps coming back after treatment, or for those little umbilical granulomas in newborns that won't stop weeping, key times to get a specialist opinion.
Okay, nearly there. Bringing it to a close. What's the overall outlook?
The prognosis. Generally, it's excellent. It is benign, remember. Most PGs respond really well to treatment. Complete resolution is the norm. You just need to warn patients about that recurrence possibility, especially if triggers are still there, like hormones or irritation.
Yeah.
But yeah, mostly sorted successfully. And those pregnancy ones often just disappear post-delivery, which is great.
And finally, any complications, even rare ones?
Uncommon, but yeah, possible. The bleeding is the main one. Sometimes it can be quite dramatic. Ulceration of the surface can happen, like any skin procedure. Tiny risk of infection or scarring. And if it's big or somewhere obvious, cosmetics can be a concern.
Right.
Usually, with proper treatment and follow-up, these are minimized.
Right. So there we have it. A deep dive into pyogenic granuloma, really honed for MSRA revision. We've unpacked what it is, what it definitely isn't, the triggers, who gets it, what it looks like, the crucial differentials, investigations, all those management options, the generally good outlook, and potential complications.
I think for the MSRA, the absolute core things are spot the classic picture rapid red bleeder, but always have malignancy on your differential, especially in adults, and know that biopsy is often needed to rule it out. That's non-negotiable, really.
Definitely. And maybe a final thought for you to mull over as you revise. We talked a lot about hormones, pregnancy, certain meds, all influencing this condition. Why is that link so strong? What does it tell us about the underlying drivers of this crazy blood vessel growth? Could figuring that out lead to, I don't know, new treatments down the line? Something to think about. For more free MSRA revision resources, do visit freemsra.com, and for the full premium revision toolkit, head over to passthemsra.com.